أهلا بيكم. Today we're going to study the root of the neck. Let's start. The root of the neck is a transition zone between the upper limbs, thorax, and the neck. So you expect to find vessels coming to and from the upper limbs, structures coming from the head, and so forth. It's right above the thoracic inlet. The thoracic inlet is the area bounded by the first rib, manubrium, and the vertebrae. The one you see here, this is the thoracic inlet. So the area right above it on both sides is the root of the neck, of course, with the middle one too, where the trachea and esophagus are. The contents, a lot actually. You have the subclavian vessels, you have the common carotid artery, internal jugular vein, I mean the major vessels. We have the trunks of brachial plexus, the sympathetic trunks, the phrenic, vagus, and recurrent laryngeal nerves, the terminal portion of the thoracic duct on the left side, and the right lymphatic duct on the right, the esophagus, the cervical esophagus, the cervical trachea, the brachiocephalic veins at very low down, formed by union of internal jugular and subclavian veins, and I think it's the most important structure here, the cervical pleura with the lungs apical segments inside. This is very important information because this means that a deep injury in the neck may cause pneumothorax if it punctures the pleura. Please put that in mind and keep it. Okay, we'll start talking about the subclavian arteries. Of course, we have a right and left subclavian arteries, but both of them are a different origin. The right arises from the bifurcation of the brachiocephalic trunk. The left arises low down from the arch of the aorta directly and goes up with the same course of the right one. So remember, the right one is shorter than the left one. The left one is lower origin than the right one. This is how they deal with you with MCQs. So pay attention to these fine details. The the subclavian arteries arch anterior to the pleura of the lung, behind the internal jugular vein, and behind the scalene anterior muscle, which differentiates them into first part from the origin to the scalene, second part behind the scalene anterior, and third part distal to scalene anterior. Branches of the subclavian arteries all come from the first part of the artery, except for the right costocervical trunk that arises from the second part. I think it's because the trachea is slightly shifted to the right, so it gives no room for the artery to costocervical trunk to arise from the first part. This is my explanation of the thing. Branches are vertebral, thyrocervical trunk, internal thoracic or mammary artery, and costocervical trunk. The first branch is the vertebral artery. It enters the foramen transversarium of C6, not 7. Be careful with that. It ascends in the foramina transversaria of C6, 5, 4, 3, 2, 1. And once it reaches the atlas, it curves medially and pierces the posterior atlanto-occipital membrane to find itself in the foramen magnum to enter the posterior cranial fossa, where it will supply the occipital lobe and the infralateral surfaces of the temporal lobes. This is a short brief about the vertebral artery. We will discuss it in details later on when we enter the skull. The second branch is the thyrocervical trunk. You can see it here. It varies in length, by the way. It may be very short stump or a long one. The thyrocervical trunk arises medial to the scalene anterior. Of course, all this is medial to the scalene anterior muscle from the first part of subclavian and divides into three main branches. The inferior thyroid artery, the one you see here, and the transverse cervical artery, or they call it the superficial transverse cervical artery, this one, and the suprascapular artery, this one. Now, the suprascapular artery will go back. It crosses the scalene anterior, so it becomes part of the posterior triangle. That's why we mentioned it in the posterior triangle. It arose in the anterior triangle and crossed the scalene anterior and became part of the posterior triangle. It goes backwards till it reaches the upper border of the scapula, and right above the transverse scapular ligament, which arches over the foramen notch of the scapular notch, on the upper border, it goes into the posterior aspect of the scapula, the supraspinous fossa. Well, it will supply the supra and the infraspinatus muscles and shares in the anastomosis around the scapula. The transverse cervical, or the superficial transverse cervical, also arises in the anterior triangle from the first part of the subclavian, crosses the subclavian artery, crosses the scalene anterior muscle, so it becomes part of the posterior triangle, and it goes backwards, crossing the prevertebral muscles, where it divides into superficial and deep branches. The superficial, of course, it supplies the area, but I mean the terminal branches. A superficial branch deep to trapezius, and the deep branch deep to rhomboids, supplying both muscle groups. This is the transverse, or the superficial transverse cervical. The inferior thyroid. Inferior thyroid artery is considered the continuation of the thyrocervical trunk. It goes upwards, then curves medially, and curves medially behind the carotid sheath with its contents. First, it was medial to scalene anterior, then became anterior to scalene anterior. Pay attention to these fine details, because this is how they play with you in multiple choice questions. First, it was medial to scalene anterior, then anterior to scalene anterior, and of course the phrenic nerve, because the phrenic nerve is underneath the fascia covering the scalene anterior. Curves medially behind the carotid sheath and its contents, means behind the common carotid, vagus, and the internal jugular vein. And in a cadaver, you will see numerous branches arising from the inferior thyroid, because it's actually the major supply for the trachea and esophagus. It supplies, of course, the thyroid, because it's named the inferior thyroid. And it gives off an ascending branch. It's called an ascending cervical artery. This ascending cervical artery ascends over the longus colli and longus capitis muscles. It gives, it supplies the prevertebral muscles as well as the spinal cord, spinal branches. This is very important. Always be careful in the surgical field not to cut important arteries that may put the patient in permanent hemiplegia, for example. So it gives off, we said, tracheal, esophageal, ascending cervical, and supplies eventually the thyroid gland. It supplies major of the inferior aspect of the thyroid gland and the parathyroids, actually, because the superior parathyroid are level with the isthmus of the gland, so it supplies both the superior and inferior parathyroid glands. Please pay attention to the fact that the recurrent laryngeal nerve, we'll see it in another drawing, the recurrent laryngeal nerve intermingles with its branches. Look at this specimen here. This is the scalene anterior. You have seen this before. This is the phrenic nerve. the internal jugular vein, the vagus nerve, the common carotid artery. This is the vagus nerve, the right vagus nerve, giving the right recurrent laryngeal that curves loops around the first part of the right subclavian artery, because the left one has a different story. See, it ascends here behind the trachea and between it and the esophagus. On the right side, we say behind the trachea because the trachea is shifted to the right. On the left side, we say just between the trachea and the esophagus. See how it intermingles with the branches of the inferior thyroid? It passes either posterior or anterior or intermingles with the branches. So be careful in surgery while dealing with this nerve. Now there is one more thing I want you to know that will let you make things easier. See this? See this arrangement? Sympathetic, common carotid, vagus, internal jugular vein, phrenic, nerve, vessel, nerve, vessel, nerve. Learn this as anterior relations of the scalene anterior. From medial to lateral, nerve, vessel, nerve, vessel, nerve. Sympathetic with its middle cervical sympathetic ganglia at level of C6, common carotid artery, vagus nerve, internal jugular vein, and the phrenic nerve. That's it about the thyrocervical trunk. Now there's another branch, the internal thoracic, or the old name is internal mammary artery. It comes from the inferior aspect of the artery, first part of the subclavian artery. There it is. See that? There it is. Descends behind the brachiocephalic vein and enters the thoracic cavity, right behind the posterior surface of the ribs, but anterior to the transversus thoracis muscle that lies on the back surface, posterior surface of the anterior ends of ribs. So it will be in contact with the intercostal spaces. Actually, it gives numerous branches there. It gives a couple of branches in each space and ends by dividing into two major arteries, superior epigastric and musculophrenic arteries. We will study these later in the abdomen. So this is the internal thoracic or mammary artery. The costocervical trunk. Costocervical trunk, we said the right one arises from the second part of the subclavian, while the left one arises from the first part of the subclavian. It goes backwards, deep in the neck, and ends by dividing into superior and inferior branches, supplying the back aspect of the posterior triangle and the ventral aspect of the trapezius. And that's it about this artery. Just remember the variation of the origin. By the way, in many books you will find that it always comes from the second part. But I told you, my source is Gray's Anatomy, and I trust Gray's Anatomy. And this is actually what I've seen in the dissecting room. It gives off a deep transverse cervical parallel to the superficial transverse cervical that cut through to the posterior aspect of the posterior triangle, and becomes or gives off the supreme intercostal to supply the first two posterior intercostal spaces. So don't forget that when we come to the thorax, and we'll talk about the blood supply of the thoracic cage. Remember the costocervical trunk, because it terminated by giving a deep branch, an inferior branch that's called the supreme artery, supreme intercostal artery, that supplies the first and second posterior intercostal spaces. See, this is another beautiful specimen of the showing the subclavian artery. This is the subclavian artery, the brachiocephalic trunk. The vagus nerve giving off the recurrent laryngeal part of it is present. This is the internal thoracic artery, and this is the subclavian passing behind the scalene anterior, there it is, the third part of the subclavian, became the axillary now after passing the level of the first rib and the clavicle. See that this is the suprascapular artery. This is the transverse cervical. Don't worry, the transverse cervical here arose very high from the maybe from the inferior thyroid. You will get all these variations, so don't worry about that. But the course eventually does not change. It's the same. The origin may vary, but it's the same. See here the trachea. Okay, you're well oriented now. This is the internal thoracic on the left side. You see that? See how it descends, gives pairs of branches, see, in each space? This is the internal thoracic artery of the left side. Beautiful specimen. Okay, if you want to talk about the veins, the subclavian vein, it's opposite the artery. It's a continuation of the axillary and ends by joining the internal jugular vein to form the brachiocephalic. Note that the brachiocephalic vein on the right side is much shorter than the left brachiocephalic. This is the left brachiocephalic. And remember this course of the left brachiocephalic, because you will understand then why the inferior thyroid veins on both sides drain into it. It's not that the right side into the right and the left side into the left. No, both into the left because of this course of the left brachiocephalic vein. The only tributary of the subclavian vein is the external jugular vein. So for the corresponding veins that corresponds to the arterial branches, the transverse cervical and suprascapular and so forth, they do not drain into the subclavian vein. Instead, they drain into the external jugular vein. And we talked fully about the external jugular vein before in the posterior triangle. Of course, the internal jugular vein is the major vessel. It started at the base of the skull of the jugular foramen, continuation of the sigmoid sinus. And now here it is, it descends in the carotid sheath with the common carotid artery on its medial side and the vagus in between and posterior. Of course, you know now this arrangement in details. Okay, what else you will find at the root of the neck? The phrenic nerve. Phrenic nerve is a somatic nerve. It's not a cranial nerve. It's a spinal nerve coming from the cervical plexus, root value C345. It descends down. Actually, it was, I told you, the nerves arise from the posterior aspect of the scalene medius, most of them. It was lateral to the scalene anterior and then descended down. As it descends, actually it doesn't cross or nothing. It descends straight forward downwards. But because of the oblique course of the scalene anterior, so they say that it crosses the muscle from lateral to medial. So don't get confused. It just descends straight forward to downwards. And as it goes down, because of the oblique muscle behind it, it crosses the muscle from lateral to medial. An important fact, and MCQ question here, is that, and they always insist on it, the phrenic nerve is buried under the investing layer that covers the scalene anterior. So you have to dissect the fascia to get to it. Actually, this is an extra protection for this vital nerve, because injury, remember, injury to the neck doesn't necessarily has to affect the trachea to impair breathing. No, it may cause paralysis of the right side of the diaphragm because of the injury of the right phrenic nerve in this case. The right side of the diaphragm won't work, so it's impairment of respiration, impaired breathing. This is very important. The vagus nerve, it's the 10th cranial nerve, and of course, we will talk a lot about cranial nerves when we get inside the skull. But now we're dealing with the vagus nerve as it goes down here in the root of the neck. As I told you, it comes down in the carotid sheath, posterior and between the internal jugular and the internal carotid, and then internal jugular and common carotid. And as it goes down, it enters the thorax. Remember, the nerves always enter the thorax between the vein and the artery, between the subclavian vein and the subclavian artery. Means anterior to subclavian artery, posterior to subclavian vein. This is how it plays in MCQ. As it goes down, on the right side, it gives off the right recurrent laryngeal nerve. On the left side, it continues down and it gives off the left recurrent laryngeal nerve under the arch of the aorta, and it gives off cardiac branches as it goes down in the root of the neck. Cardiac branches. I noticed something. The autonomic branches, either from vagus, but especially from the sympathetic chain, the organs supplied are distal to the origin of their nerves, because in the embryo everything was packed together. There were no actually large distances between the nerves and the organs supplied. But as the fetus grows, the organs grow with it. It pulls down its nerve supply. So that's why when you study the sympathetic chain, for example, I'll tell you about the superior and middle inferior cardiac nerves. They all cardiac for the heart. They arose in the neck, but it goes down to supply the heart. Okay, this is the story of the vagus nerve at the root of the neck and the recurrent laryngeal nerves. Remember the loops of the recurrent laryngeals. Okay, now you know that the right recurrent laryngeal loops around the right subclavian, the left loops around the arch of the aorta. Which nerve is longer? You tell me. Okay, this is another beautiful specimen of the root of the neck. I just wanted you to see this long nerve. See this one? See this one? This is the phrenic nerve here. This is the phrenic nerve. This is the subclavian artery, the internal thoracic artery, thyrocervical trunk, the suprascapular and transverse cervical arteries. See that? See, I wanted to show you here the internal thoracic artery. This is the vagus nerve. Now, how do I know this? By anatomy. I know their positions. So that's how I differentiate it. I don't confuse this with an artery, for example, or this. Don't count on that. Count on your information in anatomy to decide which structure is this. Don't get confused, and it will get easier as long as you practice. Okay? Okay. Now, totally different subject. The sympathetic nervous system, the cervical sympathetic trunk. The sympathetic trunks are long trunks starting at the base of the skull, goes down till it ends by uniting with its companion of the opposite side in front of the coccyx to form what's called the ganglion impar. Impar that it's not paired, only one ganglion. So they fuse together in front of the coccyx downstairs, okay? Now, it's punctuated by a series of ganglia. The idea of the sympathetic chain is, you know, the distributor, the electric distributor, if you have one terminal switch in the wall and you want to supply to give power to many devices, so you bring this distributor where you can connect your devices, and it has only one end that you will connect it to the wall. So the source, which is the switch in the wall, actually supplied all these devices, although it's only one cord coming out of the wall. Remember this. This is the same idea of the. Actually, they took this idea from the sympathetic chains. The sympathetic chains formed by what so-called white rami communicantus that arise from the intermediate cell group in the spinal cord between the anterior and posterior groups. This group only exists between from T1 through L2 levels of the spinal cord segments because it gives off the power, which is the white ramus communicantus, this one. It goes out of the spinal cord with the anterior horn, means with the anterior root of the spinal nerve. Then, after forming the spinal nerve and coming out of the intervertebral foramen, it leaves the nerve as a white ramus communicantus. Now, this white ramus communicantus with synapse with a bunch of cells waiting for it, and these cells will give extensions upwards and downwards. And then the chain, after it's formed, it will give off a gray ramus communicantus, this one, that goes with the nerve to be distributed with the nerve. So that's how you get supply, sympathetic supply to all of the body from only T1 through L2 segments of the spinal cord. Remember the story of the white ramus communicantus and the gray ramus communicantus. So you expect that the sympathetic chain, all over its length, it gives off gray rami communicantus to all spinal nerves, but only in the thoracic and upper two lumbar levels it gives off white ramus communicantus. Did you understand this now? The spinal nerves connected with white rami communicantus from T1 spinal nerve through L2 spinal nerve. See, got that? It's very simple and very easy, but it's rather confusing in the books. Okay. We said it's around the vertebral column to the coccyx. In the cervical region, it has three ganglia. It has the superior cervical sympathetic ganglia, and actually you can see it here. It's very clear. See that with the zoom? This is the superior cervical sympathetic ganglia with all the branches arising from it. It's the gray rami communicantus. And forming plexuses, see, it forms plexus around, it gives off, here for the nerves, and form plexuses around the common carotid, internal carotid artery. When I say it forms a plexus around the vessel, well, for example, if we take, for example, the internal carotid artery, eventually it will enter the skull, right? To supply structures there, to supply the brain, to share in the supply of the eye by the ophthalmic artery. Now, when we talk about sympathetic supply for the levator palpebrae superioris, for example, or for the dilator pupillae muscle in the eye, and you wonder how it got there from the sympathetic chain, well, it reaches the organ via the plexus around the vessels. So actually the vessels in the brain, inside the brain, they do not only deliver electric power, deliver blood, they deliver electric power as well with the plexus around them. The superior cervical sympathetic ganglia, it's at the level of C1 and C2. It's beautiful dissected here, you can see it. It gives gray rami communicantus, and you know now the story of the rami communicantus to the upper full spinal nerves. It makes a plexus around the carotid arteries, It supplies the pharynx and sends a superior cardiac nerves, so a bunch of superior cardiac nerves to supply the heart downstairs in the thorax. See, it's very early, but because of the growth of the fetus. Middle cervical sympathetic ganglia, it's present at the level of C6 and gives off gray to nerves C5 and 6 and gives the middle cardiac nerves going to the heart. The inferior cervical sympathetic ganglia at C7 level and anterior to the neck of the first rib. It supplies the rest, gray to the C7 and T1, and makes a plexus around the vertebral artery. This is how the sympathetic supply reached the posterior aspect of the brain. See that? By the vertebral artery, plexus around the vertebral artery, and also sends a bunch of inferior cardiac nerves to all share in the cardiac plexuses at the posterior aspect of the heart to supply it. So don't forget that. Now, a stab injury to the neck or any lesion in the neck that they may involve the sympathetic chain will produce what's so-called the Horner's syndrome. Horner's syndrome occurs at the same side of the lesion of the sympathetic chain, and it's characterized by ptosis, the P is silent, ptosis, meiosis, anhidrosis, and enophthalmos. Sunken eye, anhidrosis, lack of sweating, because sympathetic is cut, so dry skin at the affected site, and actually with dilated vessels too, so the patient suffers from hot skin with hot dry skin because there's no sweating. Meiosis, because the dilator pupillae muscle is paralyzed and the constrictor pupillae muscle is taking over now. Meiosis. Ptosis, because the levator palpebrae superioris muscle, the one that elevates the upper eyelid, is partially supplied by sympathetic that reaches it through the plexus around the internal carotid artery. Exactly. So when it's weakened, it can't hold the upper eyelid in place anymore. So you get ptosis, the dropping of the upper eyelid. Ptosis, meiosis, anhidrosis. Remember that it's like your name: ptosis, meiosis, and anhidrosis. Very famous case that you will encounter in exams. Horner's syndrome. Lymphatics. Now the map of the body is that 3/4 of the body is taken by the thoracic duct, which is at the left side, and the upper quarter of the body, which is the right hemithorax, the right upper limb, and the right half of the head and neck, is taken over by the right lymphatic duct. Okay, so we have a left lymphatic duct and the right lymphatic duct, and there may be no duct, right lymphatic, there may be 3 ducts, because actually they normally fuse. I can't say normally, all conditions are normal, it's just variation. They fuse together and to form a short duct like the left one, but in most cases the ducts involved open separately. The thoracic duct, which is the major one, forms in the abdomen, structure called cisterna chyli. Then it ascends through the diaphragm to the left side of the esophagus, continues its ascent until it goes behind the left brachiocephalic vein. It arches laterally, remember that? So when it arches laterally behind the brachiocephalic vein, it crosses the thyrocervical trunk, it crosses the origin of the vertebral artery, it crosses the phrenic, right? All these are multiple choice, easy. Don't learn them by heart. As long as you understand the anatomy of the area, you will figure it out. The thoracic duct curves laterally and then goes inferior to open at the junction of the left internal jugular vein and left subclavian vein. It's joined by the jugular trunk, the one that gets lymph from the left head and neck, left side of the head and neck. Subclavian trunk, the one that brings lymphatics from the left upper limb, and the bronchomediastinal trunk, which brings lymph from the left thorax. Okay, this is the thoracic duct. Now, a very interesting question I encountered in the FRCS exam. If you cut the thoracic duct after a meal, what will you find? Well, after a meal, lymphatics are the major absorption system for lipids from the intestine, right? The chylomicrons. So you will find chylomicrons. It's like a thick, milky fluid inside. Now, what type of blood cells you will find there? B lymphocytes or T lymphocytes? Well, it's T lymphocytes, the wandering lymphocytes. B lymphocytes are for the humoral defense mechanisms, i.e., it stays in place in the lymph nodes, while the soldiers wandering all over the body are the T lymphocytes with all the subtypes. Okay? This is what you will find at the root of the neck. Now, short talk about the cervical esophagus. It starts at continuation of the pharynx. This is the pharynx. Okay? Until the end of the larynx. Now, this is the beginning of the esophagus at the level of C6. And it continues down, of course. It's a 25 centimeter muscular tube. The upper part of the esophagus is supplied by it's formed of mixed skeletal and smooth muscles, and as you go down, it turns into pure smooth muscles. It's on anterior to the vertebrae and the longus coeli on top in the median position. But remember, at the root of the neck and thoracic inlet, it's slightly shifted to the left. Remember, the stomach at the left side, so the esophagus will go towards its side. It's slightly shifted to the left. Maybe because of the narrow space there, the trachea went to the right and the esophagus went to the left, and it's a maneuver to overcome the tight space. The blood supply of the esophagus here in this area is from the inferior thyroid artery, lymphatics to the deep cervical lymph nodes, parasympathetic from the recurrent laryngeal nerves. See, it makes sense. It's logic. Recurrent laryngeal nerves, branches of vagi, so they will bring parasympathetic to the esophagus. The sympathetic, what do you think? How do you think comes to the esophagus? Through a plexus around the inferior thyroid artery. So here in the head and neck, plexus is actually in the abdomen too. Actually, in the upper limbs and the lower limbs too. The sympathetic plexuses are very important. Okay? All over the body, it's important. Don't forget the fact that arteries do not deliver only blood, they deliver power, electricity too. Okay? Deal. The cervical trachea, of course, starts at the end of the larynx, below the cricoid cartilage by the membrane and ligament called the cricotracheal ligament. It's the most anterior median structure, see? Anterior to the esophagus. and it's formed of fibrous tissue intervening between cartilage and strings. And remember that it's not a complete circle in cut section. It's rather C-shaped, and the posterior part, which is flat, is formed by the trachealis muscle, which is a smooth muscle and responsible for the spasm of the trachea. Remember, the cut section of the trachea is like a capital D. Okay. For the relations, I thought I might say the relations of both the trachea and the esophagus one time. The thyroid is at front, and the size of the trachea and goes back, the posterior surface goes back to the size of the esophagus. Don't forget the carotid sheath with its contents at the sides, and don't forget the recurrent laryngeal nerves that on the right side it's slightly hidden by the trachea, shifted to the right trachea. On the left side it's between the trachea and the esophagus, and all these structures of course are wrapped inside the pretracheal fascia, the one we talked about in the first lecture about the fascia of the neck. Now there are two surgical procedures, one for emergencies, which is the cricothyroidotomy. Cricothyroidotomy means you puncture the space between the area between the cricoid cartilage and the thyroid cartilage here to get access to the larynx as a lifesaver. If someone swallowed anything and he can't get it out, for example, with a small knife you cut this, you feel the prominent thyroid cartilage, and you go at the lower border and you make a small cut and go through, the patient will start to breathe. The one that takes place in the operating room, operation theater, is the tracheostomy. This one you need a permanent installation of a breather, a sort of cannula that tracheostomy tube that the patient can breathe from, maybe because he has cancer larynx, any condition that obstructs the higher airway passage. So you go beneath it and you make this permanent. Maybe I used, when I worked at the Cancer Institute, I used to make lavages to the trachea of a patient every day. You inject saline, injections of saline, and he coughs it out with all the mucus. This is a very bad condition for cancer larynx patient. Thank you for listening.